Visible to all?
Yes, very nicely visible.
Thank you, Dr. Mahipal, Namrata, and all the GC members for calling this meeting. This was India Today cover, which came today, thanking all the doctors and had a very positive feeling about this. Uh, because this document, which has been prepared in a shortest possible time by the hard work done by primarily Mahipal and Namrata and Rajesh. Believe me, this 101-page document required a lot of meetings. I'm told so many man hours and so many webinars and virtual meetings. And hats off to this visionary of ours who's leading AIUS today. And believe me, this was required and was the need of the hour. And the commitment shown by Dr. Namrata and Rajesh have to be applauded. And so many names are there. Maybe some one of them may be missing. I'll deliberately read out all these names: Kumaran, Rajshekhar, Namrata Mahipal, Ravindra, Nirmal Frederick, Dr. Zamindar, Satanshu Mathur, Deepak Mishra, Mandeep Jot Singh, because he made the lot of effort in writing this document, Rohit Saxena, Dr. Partha Biswas, Dr. Jagdish Reddy, Gagan Duneja, Renu Sinha, Sunita Dubey, Arup Chakravarti, Nikhil Gokhale. The reason I'm reading is because you see a lot of effort has gone into it and you just see the end result. And also, do not forget, these people who are working beyond office hours also. You see, normal duty time is say 9 to 5. I see them working beyond midnight virtually every day, Kirpal and Rakhi. And believe me, the AIS back office requires a lot of applaud. And these are the unsung heroes. And I would recommend to President and Secretary to do some financial compensation for these people also. But they have put in a lot of hard work. So coming to these guidelines, I think Michael said very clearly, these are broad guidelines. They may not be all inclusive. And we have not got into each specificity of temperatures and humidities. And we have tried to make it as simple as possible, because we have to keep in mind the needs not only of institutions, but primarily the common ophthalmologist, so that he can start his work. Some audio is coming, Chitra. No. So, because if we make too complicated, this will, be negative for a common ophthalmologist. And sometimes legal issue may also arise that your guidelines are saying this and you have not adhered to this temperature or AHU or such things. So that is the reason I think I remember Mahipal telling again and again, please simplify, because I don't want to hear that, our common members, because we are working for more than 25,000 members. So just keep in mind this. And lastly, these are dynamic things. And Mahipal had hinted that, whatever we were a couple of days back, now it's a different ball game now. So this still may change. So therefore, I've listed these are dynamic things. So what this, from the OT point of view, the routine operation theater asepsis, in any case, you have to follow as usual. But there are some, changes when you are recommissioning your operation theaters after this, sad episode. What you have to do is overhauling, clean of the OT zones as per protocol followed by the hospital. Air sampling for culture sensitivity is preferable because you're opening after a very long time. Swabs and culture sensitivity as per the protocol of your own organization should be done. And once they come out negative, you should start the operation. Staff, I think, has been emphasized. Same is true for operation theater also. Consent of staff also is required. We often ignore our staff. They are concerned on our patients. Take their consent also, because we have that consent form in this booklet as well as in our AIS website. Also subject them to thermal scanning and also take their history. It is mandatory. Also, the physical parameters for the anesthetists and the housekeeping staff, like cap, 3-ply mask, nitrile gloves, protective glasses, goggles, and linen OT attire, and separate zoning for the staff is required. The CSSD area attire and physical parameters are by and large same, as I said: cap, 3-ply mask, gloves, protective face shield. Aim is to minimize the aerosolization. Remember, this is a respiratory virus. Aim is that minimal aerosolization, so you have to protect your face, but nothing from nose or mouth goes inside. And that is the reason of wearing gloves and mask. These are the two important things which should be adhered to all healthcare providers. And OT staff and surgeon attire, Please, for God's sake, do not, mix up the eye operations with COVID kind of surgical OTs, where those, strict PPE equipments are required. But thankfully for our OT, so many rigid things are actually not required. So don't go for those very rigid kind of PPE equipment. So cap and this 3-ply mask, oblique N95 mask are good enough. Your routine sterile gloves are good enough. And protective glasses during surgery, depending on whether you're using a microscope or not. I, for one, I tried, believe me, because in our OT technician had put up, it was very uncomfortable. So as soon as I started surgery, I had to take it off. So depending on whether microscopic or non-microscope, use that. And normal OT footwear, I think, is good enough. You can wear, the foot cover, but linen OT attire and surgical gown is good enough for majority of these surgeries. Patient flow, this is important, because this is important where you need to change slightly that distancing, which we are not used to. We keep calling so many patients inside theater. That has to be adhered to, that you do not, like for injections, call one patient at a time, one patient is out waiting outside and one patient waiting in the ground floor. And floors, furniture, and this has to be disinfected by surface mopping, especially in between GA cases, because during GA there has been a lot of aerosolization. So give around 15-20 minutes. Let the staff clean by surface mopping. This is important. In between local cases, it may not be required, or between topical cases, it may not, but between GA cases, it has to be adhered to. Operation theater, majority surgeries should be preferably under topical or local anesthesia with minimal possible staff. You see, minimal possible observers also. So teaching may take a back seat. The observers and the fellows may not be allowed to frequently come inside the operation theater. So as far as minimum staff, minimum means surgeon, the OT nurse, the anesthetist, and the running nurse, floor nurse, which keeps getting the equipment. And always segregate the biomedical waste at the source itself, as per the color coding, which you all know, and ensure safe and sterile use of consumables. That is very important. It's not always important to open a fresh pack for everything, but safe and they should be sterile, maybe ETO'd. Surface cleaning of equipment, OT table between cases, as I have said, between GA cases is a definite must, and I think Mahipal has already emphasized that. For people who have AHUs and people who don't have AHUs, people who don't get disheartened. Even AHUs, people who have, can be functional in between. That means positive ventilation is okay, but just ensure that maximum air exchanges and fresh air intake as per the HVAC. And temperature, humidity control should be as appropriate. And people who do not have AHUs, as I said, do not be disheartened. Split AC can be used, and non-COVID OT can have standalone air conditioners, but recirculate the air with single occupied zone in the operation theater. Again, temperature, humidity to be appropriately controlled, but also during this time, clean more frequently, as because of this COVID crisis. Operation theater for GA cases, surgical. This is also very important. We are not used to such kind of working. Surgical team to enter the OT after intubation induction. The anesthetist has to give a green signal, go ahead signal, and then only the surgical team will enter. Otherwise, they keep waiting in the outside area. Then anesthetist team to wear slightly more rigid for GA PPE equipment compared to a local or a topical case. So 3-ply mask, N95 is a must. Cap, gloves, goggles is a must for anesthetist, as well as face shield, because he has to protect anything which for contamination through aerosol. After surgery, again, the surgical team goes first outside and waits outside the OT and D gowns only after the patient is being shifted from to recovery room. Biomedical waste, I have already said, use appropriate color code covers, but very important, biomedical waste should leave your hospital at the earliest. Within 48 hours, they should be leaving. Instrument cleaning, just follow your routine protocols. The cleaned instrument have to be packed and autographed appropriately, but they should be cleaned before you do all this packing. Patient attire, again, one thing which has changed here is patient normally should never enter the OT with their street clothes. So you just change the clothes as per your hospital. Plus also, he will wear a mask before. So that is very important. Even though he may have some issues, you can solve that. but all patients who enter the OT have to wear a fresh. Sometimes they may be coming with a mask which has been used for days and days. So insist that a fresh, if they don't have, please provide from the hospital a fresh 3-ply mask. Draping, again, couple of words. Draping, all of you do very nice drapings, but draping should be done with a linen and adhesive eye drape so that there is minimal spillage of fluid. And drape should be firmly stuck around the patient's eye and all around. Plus, very important is that take care to ensure that the drained fluid or whatever is overflowing is not spilled. And you can put some, suction tube over there if there is too much of surgery, like which has a lot of fluid coming out. So this is different than what we have been used to. So this, I thought, maybe some points which may be helpful for our fellow colleagues. Thank you for patient listening.